So we'll begin with the first one. Presenting author is Dr. Haimanti Chaudhary. Yeah. Who? Acha, after this. Dr. Nandini. Who's Dr. Nandini? Straight after this we can have you. Will that be all right? Okay. Big button. This is what? These people are not going to come, the crosses? Okay, okay. Do you have a pen with you? Thank you. Yeah, please go ahead.
Good afternoon. I will be talking on exploring novel artificial intelligence-derived dry eye analyzer in clinical practice. Financial disclosure, none. Conflict of interest, none. Artificial intelligence has taken its grasp over the healthcare system, and ophthalmology, as one of the most dynamic stream, is largely influenced by AI and AI-derived software. There has been few encouraging reports of AI-derived algorithm in the diagnosis of dry eye in the current literature. The deeper forms of AI machine learning is utilized for the interpretation of NIBUT and interferometry, whereas deep learning is used for doing mammography imaging. When we consider the market of dry eye, it is hoarded with these imaging devices, and it is often not possible for a standalone ophthalmologist to acquire all of this. This is where the multi-imaging integrated device comes into play. Our purpose is to explore the diagnostic potential of novel AI-derived dry eye analyzer in clinical practice of dry eye disease. Methodology is a prospective, comparative, non-interventional study in 520 subjects. Ethics committee approval was obtained. For patients presenting with signs and symptoms of dry eye, first the Ocular Surface Disease Index questionnaire was done, then followed by dry eye analyzer. The traditional test of Schirmer and ocular staining were also done. We all know it is pertinent to sufficiently distinguish between the aqueous deficient and the lipid deficient or the evaporative kind of dry eye so that we can go in for a targeted therapy. So what does this AI device does? It measures the non-invasive breakup time, the tear meniscus height, the infrared mammography, and lipid layer interferometry. Non-invasive breakup time is based on the principle of projection of Placidus disc with white light onto the cornea, and it looks for image distortion. It gives the first rupture time, the average rupture time, and a breakup distribution. It generates a heat map seen right to the video of each of the picture. Tear meniscus height is measured with an inbuilt ruler in line with the pupillary center, and the above two figures here have normal TMH, which is 0.2 and 0.3 in this case, and you will note that they have normal tear meniscus volume. Compare this to these two figures below, and they have abnormal TMH of 0.12 and 0.14, and you will also note that their TMH or tear meniscus volume is lesser than the two figures in the top. Infrared mammography is based on the principle of autofluorescence of healthy mabum when an infrared light falls into it and it is captured by a coupled camera. So the first image is what you see here, and then the AI image is superimposed on it, and then we get an idea of the gland loss and the gland dropout. The first figure is a grade 1 MGD, the one in the middle is a grade 2 MGD with 45% gland loss, and the one on the right is grade 3 MGD with 78% gland loss. Coming to lipid layer interferometry, it is based on the principle that when adequate light hits an oily layer, there is colorful fringes that is generated. Now compare the two videos in the top where you will see that there are too much interference fringes versus the two videos below, which has relatively colorless picture because their lipid layer is less than normal. Our results show 51% positivity in Schirmer, 38% in corneal staining, lipid layer abnormality was found in 52%, MGD was found in 56%. We have also done a correlation between the various tests, and the one in the green or the positive values show normal report. So among all the patients coming to us with signs and symptoms of dry eye, 77% were having actually dry eye. This is the overall positivity report in all the tests. 8.6% has positive results in all the parameters. In discussion, what we already know about this device is that it is automated, non-invasive, independent of clinician judgment, it is quick, and it makes the monitoring easier. What our study adds? That meibomian gland disease and abnormal lipid layer thickness contributes to more than 52% of cases. Cases hitherto missed by conventional test, in our study 14%, could be diagnosed by this AI device. Dry eye analyzer, when used in conjunction with traditional test, is complementary. There are certain limitations of our study. There is a lack of standardized image format and analysis model. Monitoring patient scores over a treatment of time was not done. What is the translational potential of this study? This is the printout that is generated at the end of the study, and this color-coded report can be utilized to raise the patient's awareness and thus increase compliance. We can go in for image-based targeted therapy. Precise monitoring of treatment response can be done. What is the future perspective of this study? This kind of AI software can be utilized or incorporated in the smartphone and can be used for mass screening in a setup outside the clinic. Thank you very much for your kind attention.
Thank you so much for a very, very nice presentation. I just wanted to know, where have you got this artificial intelligence from? Is it in the form of a device? And is that device, let's say, validated? I just would like to know about that.
Yeah, this is a device that we got in one of the AIOC conferences. We acquired this machine. It is called Dry Eye Analyzer, and it is based on AI.
So do you think that this is basically the normative data which is present in the machine that you all have tried to utilize in order to do your tests?
The normative data is there in the machine, and it follows a particular pattern because there are certain other multi-imaging integrated device also, like the Oculus, and those are also validated.
Right. Thank you. Anything?
I just have a question. There is a standardized image format for this, what you have used in this device?
Yes, there is some, which also is in comparison with the other multi-imaging device.
Already that is existing.
Yes. Thank you very much.
Yeah, please.
Okay, next presentation is free paper 1271 by Mrs. Nandini, Topographical and Visual Outcomes in Topo-Guided PRK with ACXL in keratoconus.
Yeah, good afternoon, everyone. I am here today to present our outcomes of simultaneous topo-guided PRK along with cross-linking in keratoconus patients. I have no financial interest. So we all know that keratoconus is characterized by irregular astigmatism, reducing the patient's visual acuity, which significantly impacts patient's quality of life. So two things we need to address in keratoconus. One is the biomechanical instability, which we address by doing collagen cross-linking. Other one is irregular corneal surface. For that, we have both. We can do either a subtractive procedure or an additive procedure. Additive procedure has its own pros and cons, and most of the irregularities still persist, and the results are unpredictable. Whereas a subtractive procedure like topo-guided PRK reduces the corneal irregularity. Like in this picture, when you do a plain cross-linking, it doesn't affect the morphology of cone. Whereas when you do a simultaneous topo-guided treatment, it affects the morphology of cone. Like after the treatment, you don't even know that the patient is having keratoconus or not just by looking at the curvature map. That's why the simultaneous procedure would be recommended in keratoconus patients if they have good pachymetry. So I want to highlight on this cone location and magnitude index. This is a topographic index used to detect keratoconus. It tells the location and curvature magnitude of the cone, and easy to track the progression of the disease through the looking at the curvature magnitude of the cone. So the aim of our study is to report the outcomes of this procedure in keratoconus patients. So those keratoconus patients who underwent simultaneous topoguided treatment along with cross-linking were included in the study, and the study period was for around 2 years at a single center of Narayan Netralaya. Those who had clear corneas and those images which were captured by topolyzer whose images were reliable with a minimum follow-up of 3 months were included in the study. Once we have the data from the topolyzer, the reliable images were transferred to a planning station. Once we do the planning, then first we do a PTK of around 50 microns, then followed by a topo-guided treatment. And when we planned, we kept our RSBT to more than 350 microns, followed by accelerated protocol of collagen cross-linking. 60 eyes of 46 patients were included in the study, and out of them, only 49 eyes were analyzed because they had a minimum 3-month follow-up. So coming to the visual outcomes, the uncorrected visual acuity had improved in all patients, whereas the other parameters like sphere, spherical equal, and best corrected vision were statistically similar. If you look at the graph, if you compare the pre and post cylinder, there was a significant reduction in the cylinder, and the reduction of cylinder was around by 1.38 diopters. Even the higher order aberration and the lower order aberration was also reduced pre and post treatment, thus telling that it also improved the quality of vision. This is the vector analysis of the topographic astigmatism. Here, the red circle usually represents the distribution of the topographic cylinder. The blue circle usually represents the cylinder which is present after the treatment, and the plus is near the 0 point. So you can see after the treatment, the cylinder is coming towards the 0. That means the cylinder is significantly reduced, and the data reduction is almost around 36% that we saw after the topo-guided treatment. Even like in other studies, all the K parameters were also reduced, and this parameter is something which I want to highlight, which usually tells the amount and the magnitude of the curvature of the cone, which usually significantly reduced after the topo-guided treatment, and the difference what we can see pre and post treatment was around minus 3.64 diopter. So compared to all other studies, we are the first one to look at this parameter to know how much the cone got treated after the topo-guided treatment. So what was known earlier was simultaneous topo-guided treatment along with cross-linking can regularize the irregular keratoconic corneas along with stabilization of the keratoconus. What our study adds is, along with that, the amount of the regularization of the cornea can be quantified using the CLMI index and the vector analysis of this topographic astigmatism. And I would like to thank Dr. Abhijit and Mr. Matthew from our GROW lab who helped us in analyzing the data. Thank you so much.
Thank you.
A comparative study would have been much better, don't you think?
Actually, that is phase 2, ma'am. We are analyzing the data.
No controls in the study, right?
No, this is the phase 1 study which we wanted to see this index. Is it helpful in commenting how much regularization we get in this treatment? That phase 2 is we are comparing with the controls.
No, but then how are you going to do that? Initially, only whenever you are planning a study, it's always one versus the other.
Correct.
So was this just a pilot study?
No, it was just a retrospective analysis of the data.
But then it is also an interventional study.
Correct.
Yeah?
Correct.
And then you have made the page. You also said something about, I may have got it wrong, that for 3 months you all waited, did the, I think, the scans and waited, something like that? What was
those
that?
who had minimum 3-month follow-up.
Follow-up I understood that you had, but pre,
no, ma'am.
nothing like that.
No, nothing like that.
Right. Okay. Thank you.
Thank you.
Next this girl was who? Which one?
This was Nandini.
Nandini. Okay.
Next we'll have second one.
Yeah. Ask.
So next we have free paper 469, Novel Diagnostic and Treatment Algorithm by presenting author Dr. Bharat Gurnani.
Good afternoon, one and all. I'll be presenting my paper on novel diagnostic and treatment algorithm for pythium keratitis, redefining management guidelines. We have no financial disclosures to make and no conflict of interest. So we should know what are the existing challenges in pythium keratitis. A rare keratitis recently in upsurge. Clinically and microbiologically, it mimics fungus, hence also called as parafungus. The specific diagnostic method is a DNA zoospore identification, resistant to conventional antifungal and responds more to antibacterial as per literature, and has poor outcome with therapeutic keratoplasty, and there is high risk of reinfection and phthisis. Coming to the introduction, Pythium is an oomycete commonly seen in tropical and subtropical region, also called as parafungus. It lack agosterol in the cell wall. The purpose of our study was to analyze the demographic profile, the clinical diagnostic features, challenges in management, treatment outcome, and to propose a diagnostic and management protocol. It was a retrospective study design done during the period of October 2017 to March 2021. 41 Pythium subjects were recruited from the Cornea Clinic of the Tertiary Eye Care Center in South India. During the study period, we studied 2631 ulcers. Out of that, 1398 were culture negative, 998 had fungal positive, bacterial were 194 were positive for bacteria, and we had 41 Pythium subjects. So in the inclusion criteria, we had all clinical Pythium keratitis subjects who were culture positive, clinically appearing fungal keratitis but were culture positive for Pythium, and button culture cases post TPK which were positive for Pythium. In the exclusion criteria, we excluded clinically appearing Pythium cases but culture negative. All other infective and non-infective keratitis cases were excluded. We designed a novel diagnostic and treatment algorithm based on our experience. All the clinical cases of Pythium were subjected to smearing and culture, and before culture results, antifungals were given to all patients, and zoospore was identified by leaf incarnation method. In the culture positive arm, if the ulcer size was less than 4 by 4, they were treated with linezolid monotherapy, and if the ulcer size was more than 4 by 4, we treated with linezolid and azithromycin combination. In case of good response, the same treatment was continued, and in case of poor response, patients were subjected to TPK. And in case of early stromal melt cases, we used glue and BCL. In the culture negative arm, if the ulcer size was small, we used natamycin monotherapy. And the ulcer size was more than 4 by 4, we used natamycin, voriconazole or itraconazole combination. Good response, the same treatment was continued. In case of poor response, they were subjected to TPK. And the button culture was positive. They were treated as Pythium subjects, and we started anti-Pythium drug. And in case of recurrence requiring TPK, we did a repeat TPK. Coming to the demographic, 15 subjects were less than 25 years of age, 21 were more than 26 years of age. In the sex distribution, 40 were females and 40% were females and 60% were males. Demographic and clinical feature, the most common were farmers, 18 patients, followed by 12 students and 11 housewives. Injury was the most common mode of risk factor in 30 patients. The presenting visual acuity was less than 1 by 60 in 18 patients, and the presentation lag was less than 10 days in 20 patients. In the clinical features, stromal infiltrate with hyphated edges was seen in 15 patients, 8 had a corneal melt, 11 had subepithelial infiltrate spreading to limbus, 9 had peripheral furrowing, and 12 had tentacular projection. Hypopia and anterior chamber exudates, 18 patients, endothelial plaque was seen in 12, and perforation was seen in 5 patients. So this first image shows the tentacular projection of ulcer margin, the second shows the peripheral furrowing, third shows the tendency to spread toward limbus, and fourth shows the whitish plaque with hypopian. These are all the hallmark features of Pythium which we used during our analysis. Staining culture and zoospore identification, the first image shows KOS staining, which shows the Pythium filament. The second image shows the long, slender, linear aseptate hyphae of the Pythium. The third is a leaf incarnation with the zoospore can be seen here. And the fourth, fifth, and the sixth image shows the blood agar, chocolate agar, and potato dextrose agar, white, fluffy, cotton wool-like colonies of Pythium. Coming to drug details, before culture result, we used 19 patients given with natamycin and voriconazole combination. 12 had natamycin itraconazole. Natamycin alone, if the ulcer was superficial, we gave in 11 patients. After culture positivity, we added azithromycin in 27 and linezolid as a first-line drug was added in all patients. 13 healed with medical treatment, 28 required a therapeutic graft, 11 had graft reinfection, 4 were lost to follow-up, 5 needed glue and tarsorrhaphy, and the average time to TPK was 11 days. So this image shows recurrence of infiltrate in the post-TPK, showing the virulence, and the second shows the anterior chamber clump exudates in the anterior chamber, again showing the virulence. Third image shows total corneal melt post-TPK, and again show total corneal melt will infiltrate. Coming to complication, we had one case with evisceration, 20% and secondary glaucoma. Choroidal detachment was seen in around 27%. Graft reinfection, retinal detachment, endophthalmitis were other complications. Globe salvage rate was high, 88%. 12 had a phthisis. 9 patients had visual acuity greater than 6 by 60. 9 had 1 by 60 to 6 by 60. 19 were positive, PL positive, and 4 were PL negative. So comparing a medical group with the surgical group, there was no statistical significant association between the two groups. So in our analysis, we had 41 subjects during the study period, which is a good sample size compared to the previous studies published. Approximately 70% needed TPK, 30% healed with medical treatment. Repeat TPK rate was around 27%. One had a evisceration. Glove salvage was high, 88%, and 12 had thisis or no PL. So to sum up, pythium is more prevalent in younger patient population. Most common clinical finding is stromal infiltrated with hypatid edges, and specific findings are peripheral furrowing and tentacle. TPK is a treatment of choice. 30% heal with medical treatment. If managed aggressively, glove salvage rate can be high. Early diagnosis, meticulous management, and regular follow-up are key in managing these cases. Based on our experience as well as literature review, we further refined our protocol. We added the newer strains which are available recently, and this is our protocol for the study period. Thank you, ma'am.
This is a very, very nice study, and indeed, to get so many cases and to diagnose them, I think, is remarkable. And the fact that you will have salvaged so many eyes, again, is remarkable. But it's also very, very, what has caught my attention is that you've said that it's basically students who are getting it. So I was wondering how come. You said farmers 18, and the rest of them are students. Why such high number of students?
That was, ma'am, slightly challenging to know why they are having. We were also not able to, like, there was a young patient, 21 years old. We were not able to see why this patient developed. He had a history of clay use. So he told me, I am working with clay and something like that. He was a professional. So maybe it's due to mud induced or soil.
But none of the other publications have talked about what is the etiological factor causing it.
Other publication also speaks on the same guideline. Like few studies have seen more than 50% to be housewives and software professional or younger generation, and other one or two studies have seen like 60% to be farmers. So there is a mixed literature available on this. So we also had similar kind of like our patient population was like around 15 patients were less than 25 years of age.
Do you feel that the corneal presentation initially looks quite different from the other presentations that you get, let's say because of other bacteria or fungi or whatever?
Well, there is a
What
mixed,
makes you suspect that?
sometimes there is a mixed picture, like you think it's a fungal only. So once you see after 5 days you have given the treatment, and when the patient turns up and your treatment not working, the ulcer has flared up, then you start thinking like maybe we are missing something. Then if you go back on to see on the culture, it comes pythium positive.
So when you are taking also the culture, let's say taking the slides, do you feel that there is a different feel to the when you're taking the infiltrate for let's say a study? At that time, do you feel that it is a different feel while you're taking the infiltrate, or it's the
Maybe
same
more
feel?
cheesy cotton, like cheesy. It's a more cheesy material compared to fungus, what I believe. Like, but it's difficult to pinpoint on the first visit, like is it fungus or what. That's why we still say like antifungals still have a role to play, because pythium being very rare, fungus being on the higher side, so we have to treat it as fungus for 5 days. Later, once the culture reports are available, only one report says that only fluorescent microscopy can differentiate the hyphae on day one, which may be a limitation since it's not available at all centers.
Thank you.
Thank you.
Yeah, yeah, please.
So, Dr. Bharat, you had excluded the consecutive ones in the beginning.
Yes, ma'am.
So, did you not opt for a PCR diagnosis in those which would have increased your study number?
Yes,
And,
ma'am.
at SM, we believe that PCR is more diagnostic compared to zoospore formation, which is more genetic practices the genus rather than.
Ma'am, this was one of the limitations of our study. Like we didn't subject all the subjects to PCR, which could have been more informative.
I think that's a very good point. Yes, yes, definitely.
All
so.
patients were not affording also, and secondly, we were not aware initially like PCR can be more diagnostic on day one. But now recent literature revealed that besides culture, PCR is the gold standard. Thank you.
Next, we have Dr. Vanati ma'am presenting topical human immunoglobulin as adjunct therapy in refractory dry eye disease.
Thank you. So, topical human immunoglobulin as an adjunct therapy in dry
Dr. Saab,
eye
can you
disease.
speak a little louder? Somehow it's not. Thank you.
Topical human immunoglobulin as adjunct therapy in dry eye disease. No financial interest here. I wish to acknowledge all my co-authors in this study here. Recent literature points towards the various pathological consequences which are available on the ocular surface, which are responsible for the refractory nature of the ocular surface disease in dry eye patients here. Of such, what we have identified is what is known as the ACPAs, or the anti-citrullinated protein antibodies in the tears of dry eye disease patients, which are responsible for the refractory dry eye disease nature, which does not respond to the conventional conventional dry eye therapy in these patients here. So you have the phenomenon of netosis and you have the phenomenon of ACPAs, which contribute to ocular surface inflammatory mediators, and thereby these not being responsive to the normal therapy which is given in dry eye disease patients. The lacunae in literature is paucity of literature on the clinical response of dry eye disease to ocular surface immunoglobulin therapy here. So the aim of our study was to evaluate the role of topical human immunoglobulin, IgG eye drops, 4 milligrams per ml, as adjunct therapy in the eyes of moderate to severe dry eye disease patients. The study design was a prospective longitudinal interventional study done at RP Center, AIIMS, New Delhi, during the period ranging from April 21 to July 22. Sample population consisted of chronic dry eye disease patients with a minimum of 30 patients in cases and 30 as controls to be evaluated over a period of 6 months. And inclusion criteria was patients more than 18 years, TBUT less than 7 seconds, Schirmer's less than 9, ocular surface disease index above 13, and corneal and conjunctival staining scores of over 3 here. The exclusion criteria was as depicted here. The study commenced after institutional ethics clearance, and a clinical trial registration number was also taken. Informed consent was obtained from all study participants here. So we plan to recruit a minimum of 60 patients, so minimum 30 in the cases group which had dry eye therapy with adjunct therapy with topical immunoglobulin given twice daily, and the group receiving just conventional dry eye therapy remained as controls. Ocular surface evaluation tests in terms of TFOS due to grading. All the ocular surface evaluation parameters were done here. Topical human immunoglobulin 0.4% was reconstituted from commercially available IVIG drops here in our in-house pharmacy here. We also computed a treatment grading score to calculate the change in the severity or the need for potent topical steroids and the frequency for lubricant therapy in terms to objectify the efficacy of the treatment in our patients here. So this is the graphic representation of patients and of the controls and cases groups here. The age is equivocal. It was a gender and age matched study here. We had follow-up data of 53 eyes who were recruited for 6 months, 14 had completed over 6 months, 4 had been lost to follow-up here. So when you look at the characteristics of at baseline and characteristics at 3rd month, 6 months follow-up, all showed a statistically significant improvement in the OSDI scores, the TBUT, the Schirmer's, the corneal and conjunctival staining scores, along with the conjunctival hyperemia scores as well, as compared to the cases group here. So the controls group here. So this shows the box whiskers plot depiction of the various scores of the patients when they were being followed up at 3 months and 6 months, and this graphical representation clearly shows an improvement in the ocular surface evaluation parameters over a period of time. The improvement in the hyperemia scores in comparison to the cases and the controls is also depicted. These are clinical pictures of few of our patients or of the study participants in our case here. There was also a change in the treatment parameters of all the patients after we applied the scores here. So what we would like to highlight here is that the use of topical IVIG drops gives a significant benefit when given as an adjunct therapy and is effective in decreasing the ocular surface inflammatory mediators and giving you a better clinical response as compared to conventional clinical therapy here. The limitation is we would probably, a larger sample size would have been much better here, and also correlating it with the clinical response with evaluation of inflammatory mediator responses would also give more objectivity in terms of understanding how the inflammatory mediators change in response to IVIG drops. Wish to acknowledge all my coordinators in this clinical study here. Thank you for your patient hearing.
Thank you, Vaniti. Dry eye is always a very, very fascinating disease, and you all have brought out something very new. I just wanted to also check back that the group of patients whom you had chosen, was there a specific etiological factor that you had found for the dry eyes?
Yes.
Was there any systemic cause for the dry eyes?
Most of the patients who were recruited in this were defined as chronic, moderate to dry eye disease patients here. They were Sjogren's patients, ocular GVHD patients here, and patients secondary to rheumatoid dry eye disease here. So they all had a definite systemic association for a dry eye disease here, and we categorized them into 2 groups here. And the phenomenon phenomenons which are now being attributed to the refractory nature of dry eye disease in these patients is the phenomenon of what is known as the net traps, the extracellular nuclear traps which are present on the ocular surfaces, which are probably inducing inflammatory mediators, or also the ACPAs, the anti-citrullinated protein antibodies which are present on the surfaces. This is taken care of when we give IVIG drops. The ACPAs respond to the IVIG topical therapy, and we have found significant clinical improvement. A large chunk of our patients are ocular GVHD patients here who are really very severe dry eye disease which do not respond to conventional treatment.
Do you think would you like to have because so many of these patients with dry eyes on because of systemic problems, let's say for example like rheumatoid arthritis, we keep on treating the inflammatory element of it with cyclosporin. Do you think that this particular therapy that you'll have come with, because it's very difficult to formulate, then in that case, do you think that this will be more
Yes,
helpful
it
than
did.
cyclosporin?
Yes, it did help. We did look at the change in the need for using immune mediators in these patients here, and the change in need for higher potency steroids, and the change in the frequency of steroids used and the lubricants used. So we gave an objective score for all of these, and all these had a clinical significant, statistically significant improvement when we had given them twice daily IVIG drops.
Yeah, the only thing is manufacturing.
Yeah.
And how that's the only thing difficulty. But thank you very much.
And next we have Dr. Bhavesh Saha presenting on tacrolimus versus interferon alpha 2b.
Very good afternoon, everyone. I'm going to present my research topic, that is the tacrolimus versus interferon alpha 2b, a comparative evaluation and treatment of VKC.
So we'd like you to speak a little louder because
Okay,
we
ma'am.
can't hear you at all.
Okay, madam. As banal conjunctivitis is a chronic inflammatory disease, mainly affects the children of first and second decade, and it is characterized by remission and relapses. As we know, that topical corticosteroids are the main drug used for treatment of moderate to severe VKC, but in long term, there is side effects such as glaucoma, cataract, and secondary infection. To prevent such adverse effect, the use of immunosuppressant like cyclosporin and tacrolimus in various extent has been tried and reported in various literature in different concentration. Tacrolimus is a immunosuppressant agent that functions similar to the cyclosporin with more potency, but has associated with the drawback like you have to prescribe long duration, resulting in poor compliance and recurrent after withdrawal. Interferon alpha, other newer agent, has been being tried in VKC in different in few articles, and some of the few articles reported very promising result. That is the one article from Turan et al. He reported very good the good efficacy in safety achieved even within 2 months of treatment, and this effect is sustained after 6 months after discontinuation of the treatment. So, and there is a very paucity of literature exists regarding the study performing interferon, comparing the interferon with the tacrolimus in recalcitrant VKC. So our research question is interferon alpha 2b effective and faster acting agent than tacrolimus in cases of recalcitrant VKC? Our research hypothesis in interferon alpha 2b is effective, tolerable, and faster acting than tacrolimus management in patients with recalcitrant VKC. So our aim to evaluate and compare the efficacy of and side effect of tacrolimus 0.03% and interferon alpha to 1 million international units per ml eye drop in recalcitrant VKC. Design was prospectively randomized controlled trial done in tertiary eye care center. Our inclusion criteria was all the verbal children or adolescents with active disease having total subjective symptom score more than 6 and total objective symptom score sign score more than 4, who were not responding to topical medication, topical corticosteroid, and topical antihistaminic after 4 weeks of regular use were considered to have a resistant VKC. Exclusion criteria was associated with ocular disease and systemic disease and reported to hypersensitivity with the tacrolimus or interferon group. Sample size was 52. After discontinuing all the topical drug, for 2 weeks, and after performing the basic observing workup, and we calculated the total subjective symptom score and total objective sign score, and it assigned into two group in group 1 tacrolimus 0 prescribed group 1 0 tacrolimus 0.3% BD, and in group 2 interferon alpha 1 million per unit 4 times a day, with along with the preservative artificial tear and cold compression for 6 months. Our total main outcome measure was total subjective symptom score and total objective ocular sign score, and second measure outcome was side effect. We score all the grading symptoms and sign according to Valik et al. From 0 no symptom to 3. Similarly, we grade all the sign from no 0 to +3, and similarly all the adverse effect are graded like burning, stinging, etc. All symptoms, side effects are graded from 0 to 3. These are the report. In both the group, male are predominant. Regarding age, in both groups it's comparable. There is no significant difference regarding age and duration of the disease. Regarding the type of BKC, tarsal type of BKC are both common in both the group. Regarding the total subjective symptoms and total ocular sign score, it comparable in both the group, and we can observe that there is a significant reduction of total subjective symptoms score in tacrolimus in interferon group at the 2 months, whereas in cases of tacrolimus it is around the 4 months. Similarly, the total objective symptoms score significantly reduced at the age of at the 4 month, but in tacrolimus group it at the 6 month. There is no significant side effect in both the group. Regarding discussion in our study, both the tacrolimus and interferon alpha are effective, but in interferon group, symptoms and signs significantly reduced at 2 months and 4th month respectively, while in tacrolimus group at 4th month and 6 month. This study, in compared to our study, Turan et al. Also reported and evaluated interferon alpha in treatment of resistant BKC, reporting good efficacy and safety with a short-term treatment, achieving maximum benefit effect within 2 months. And in contrast to Gupta et al. Also reported both interferon alpha and tacrolimus eye ointment are safe and effective, and symptoms are significantly reduced at 6 months, but signs are reduced at 1 month in both the group. So our conclusion, both tacrolimus 0.3% tacrolimus and interferon alpha are effective, but the later results are into faster relief from sign and symptom and more tolerable in patients with recurrent BKC. These are the limitations. We have a small sample size, short duration, unblinded study, and the future data should be a multiple randomized controlled trial. Thank you, ma'am.
In the long term, do you think that both of them will have both of them will behave equally? Effective wise.
Both group are effective, but in terms of duration, we found the interferon is better.
That's because it acts early. That's what you're saying, right? But in the long term, it is both of them are almost behaving equally.
So just tell us something that your follow-up was for how long?
6 months.
6 months. But then this disease has recurrences and remissions, we all know. So don't you think that this study should be continued for a longer period?
Yes.
In order to know which one is showing, earlier recurrence or later recurrence, because that is what we want.
We are doing, madam, for follow-up. But major concern was in tacrolimus group, there is a high dropout because it is acting very slowly in comparison to interferon group. We found.
And okay, what about the cost factor of the two?
Yes, ma'am.
And availability of the two medicines?
It is available but costly. Interferon obviously it is very costly in comparison to tacrolimus.
Yeah. So how do you all make this? Is it made in-house? How do you all get this?
No, madam. We use commercially available interferon.
Please come.
Commercially available interferon alpha of Intas. Sorry, no functional interest of Intas group and mix with the peer substitute. And we use commercially available tacrolimus 0.03%.
That's okay. Tacrolimus is so all right, but we're talking about the interferon bit of it. That is what I was wondering, because cost factor. Have you compared? What's the cost of each one?
No, ma'am. Definitely interferon group is costly.
Second is that rather the next question is that when you all were separating the children into two groups, was there any randomization, or you all just
We have done randomization both. Yes, we have done randomization.
okay? That
But
was
it
not
is
brought
not
out.
masked,
Was-
right?
Not
Not masked.
Because we have very less number of sources both, and we have no facility of in-house compounds, pharma. That's why we.
Right. Thank you.
Thank you.
Thank you very much.
Okay, ma'am.
This is a nice study.
Next, we have Dr. Pooja Kamar presenting on biomarker-enabled specific targeted therapy.
So very good afternoon to all. At the outset, none of the authors have any financial disclosures pertaining to this study. So as clinicians, everybody would be wondering that why do we need a biomarker-enabled therapy? This is how normal and stress cells look like. In a normal healthy cells, the healthy cells would eat up the dead cells which are there in the body and throw them out of the body, making space for the new cells to grow. However, if there is any inflammation present, the cells will be under tremendous stress, and any dead cells surrounding them, the normal cells wouldn't be able to eat them away, throw them out of the body. In return, the inflammatory process will keep increasing, and then this is how the disease process starts. There are various secretory molecules which are always secreted in this normal and healthy cells for the normal nutrition to go away. However, under inflammatory cells, these biomarkers, which are the inflammatory cells, they're secreted into extremely higher quantity. Now, what happens is if these are normal cells, and if you do any procedure, cataract, refractive, glaucoma, retina, the healing process is going to be normal. However, if the inflammation is higher to begin with, then the post-surgery, the outcomes are also going to be vague. The healing is going to be abrupt, and that is how the disease process is always vague. Now, what happens is if you have done any procedure in this inflammatory status, post-surgery, in spite of giving any medications, these patients are going to have a lot more chances of itching, pain, burning sensation, redness, and even in your dry eye patients, if you have not treated them correctly, these patients are in spite of your medications, these patients are going to have a lot more complaints. So the research question is that how do we identify the subclinical white inflammation which is present, which is not picked up on our normal routine diagnostic test or our clinical examination? Our lab was started around 10 to 11 years back with 3 scientists, and over the 10 years of time, we have collected more than 25,000 tear samples, and with the help of 150 scientists, we have done tear biomarker analysis to see what the inflammatory biomarkers are in each of the disease, be it dry eye disease, ocular surface disease, retinal conditions, or refractive or cataract surgery patients. And not just our group, but many group over the past decade has published this work where they've noted that various inflammatory cytokines are present commonly over these disease conditions, and they are responsible for your dry eye disease and ocular surface conditions. And they will not be treated just by your normal lubricating drops, hot fermentation, cyclosporins, or anything. There is a validated present day workflow how you can analyze these tears with flow cytometry. But the challenges faced are they're time consuming, they're cumbersome because it needs to be sent to a lab. Of course, the cost is there for both the patient and the doctor. And you have to be a lab dependent. You need to have a good lab with a good setup and a good number of scientists to analyze the samples for you. So the question here is, can we, from a vast, exhaustive lab setup for biomarker analysis, develop a point-of-care diagnostic kit which is deployable in all our clinics for easy clinician use? So we have built an ELISA-based biomarker kit which is ELISA-based, and a fluorescence reader is involved, where we can analyze 8 inflammatory biomarkers in just 90 minutes with just a Schirmer strip where you collect the tears from for your dry eye disease test. This is how it works. We do a normal dry eye test with Schirmer strip. After 5 minutes, you collect them in an Eppendorf tube, and you add a 300 microliters of buffer solution in this, and you shake the tube for 5 minutes. After 5 minutes, all the tear proteins and inflammatory cytokines will be eluted in this buffer solution, and you take 50 microliters of it and then put it in the cartridge to read the analyze. At the end of 90 minutes, you get this report which suggests that what is the level of each biomarker, whether they are normal, whether they are not. You can get a quantity of each of this biomarker, and based on the reference interval, you can see what is it, whether it's normal or abnormal. So we did a study where we included 1,080 eyes of controls, 1,300 dry eye patients and 1,000 keratoconus patients. We collected the tears and subjected them to a biomarker customized Pathfinder kit to see the biomarker levels. What we found was that this biomarker kit was easily able to differentiate the inflammatory cytokines between controls, dry eye disease, and keratoconus, and also give us a quantity of each of these inflammatory markers in all of these patients. But what was more interesting than this is you can get it, but in the control patients, which were normal according to the T-first used to classification, Thomas, T-Bert, OSDI, all was normal. Their inflammatory cytokines in 50% of the patients were still higher, MMP9, IL-6, and IL-1 beta, suggesting that the subclinical inflammation disease process has already started, and this which is not picked up on your diagnostic test. And if you do anything for them, they're going to have a severe reaction to your treatment. And not just for this patients, but a cataract surgery patient, a large proportion of subjects scheduled to undergo cataract surgery also exhibited higher levels of inflammatory markers. We did not do anything for them. However, we proceeded with the surgery. And after surgery, from this cohort, 50% of the patients with pre-op dry eye disease, with no pre-op dry eye disease, who had higher inflammation, developed dry eye disease symptoms which are not treatable. Using this data, we have built a artificial intelligence-based report software where it's easily able to identify or differentiate the controls from dry eye disease, and the AUC curve is 0.96 for these patients. And this is just easily usable for all the clinicians in the clinic, which will be able to tell us whether what is the level of the disease and what treatment should be given to the patients. So how do we use it in our clinic? If the MMP9 level is higher, you use a trehalose or a cyclosporin or a IPL-based treatment depending on the levels of high they are. If the IL-17 is higher, they are known to have pain without stain, loose epithelium, and chronic inflammation, and it is well proven. So these are the, and also the TNF-alpha factor, if it's higher, the patients can have higher post-op haze. So for these patients, the treatment would be doxycycline, steroids, or IPL-based treatment. If the IL-6 or IL-1 beta levels are higher, then these patients will need a IPL or a lubricant-based treatment. If the ICAM levels are higher, the first line of management would be a lifitegrast-based lubricating drop. And if the VEGF levels are abnormal, it helps into your ROP and dry eye disease treatment. So this is the first panel in the eye care with multiple biomarkers to diagnose various conditions, and it helps to define severity of the condition and customize the treatment. Accurately helps to monitor response to therapy and timely titrate therapy. Multi-marker strategy provides for validated, balanced approach to aid the clinician, and it also helps us to stratify the clinically healthy eyes from subclinical
and my
inflammation.
team for
Thank
helping me present this work on their behalf. Thank you.
For you. Just tell me something. This kit that you all have devised, this has been patented?
Yes, ma'am, we have applied for a patent. In fact, now we have applied for a regulatory approval. So as soon as we get the approval from the DCGI, it will be available for use for clinicians. So initially, we will not be charging anything because every center, this is the first time a biomarker kit is available for everybody. So we'll be giving it for clinicians who are interested in using in their practice. And the second thing would be once we have data from all the clinic, which will keep it in our, will incorporate in our AI-based software, then we'll commercialize it. So regulatory approval should come anytime in next 2 to 3 months from the DCGM.
Thank you.
Thank you.
Our next presenter is Dr. Taruni Kumari, topical timolol for treatment of conjunctival pyogenic granuloma.
Good evening, everyone. Today I am going to present on topical timolol for the treatment of conjunctival pyogenic granuloma, outcome and effect on IOP. Pyogenic granuloma is acquired vascular lesion commonly seen on skin and mucosal surface. In eye, pyogenic granuloma are typically seen on palpebral or bulbar conjunctiva. Conjunctival pyogenic granuloma develop as a result of inflammation from eye surgery, lesion, or any other ocular trauma. Common clinical presentation include foreign body sensation, irritation, mass, and rarely pain. Topical steroid is the most common form of treatment in a case of ocular pyogenic granuloma. Surgical excision is the next preferred treatment in steroid non-responder or recurrence case. Alternate treatment of pyogenic granuloma is topical timolol with minimal side effect. Topical steroids are known to cause rise in intraocular pressure. It can cause ocular hypertension with 6 to 15 mmHg rise in IOP. After 4 to 6 weeks, use in 30% of the healthy patient. The RAS pathway has implicit in angiogenesis and vascular proliferation through hypoxia inducible factor 1 alpha and vascular endothelial growth factor. Beta blocker work by inhibiting hypoxia inducible factor alpha and vascular endothelial growth factor, leading to apoptosis and endothelial cell involved. Now, aim of study to determine the clinical outcome of 0.5% timolol malate eye drop for the treatment of conjunctival pyogenic granuloma and its effect on intraocular pressure. This is hospital-based prospective interventional study done between January 2021 to August 2021. 11 patients with the conjunctival pyogenic granuloma who were prescribed 0.5% timolol eye drop included in my study. Patient evaluated with the slit lamp examination and IOP measured by the applanation tonometry. Visual acuity noted in each visit. Patients were followed weekly up to the 8th week. IOP were measured before treatment, while on treatment, and 8 weeks after treatment. Treatment aborted after 8 weeks if resolution not noted and surgical excision undertaken. The data analysis include the following parameter like A6, location, antecedental history, duration of complaint, previous treatment, duration of treatment, and pre-treatment on treatment. All patients diagnosed with the pyogenic granuloma were included in my study. Exclusion criteria include recurrent pyogenic granuloma at the presentation follow-up, previous diagnosis of glaucoma or ocular hypertension, pregnant women, patient with a history of bronchial asthma were also excluded. Out of the 11%, 54.5% were female and rest male. According to this bar diagram, most common predisposing factor for development of pyogenic granuloma is chalation followed by the unknown origin and trauma. The mean IOP of the affected eye at the presentation was 15.1 mmHg. 1 week after the initiation of therapy, the mean IOP was 12.1 mmHg. Palpebral conjunctiva is most common location of pyogenic granuloma in eye. Out of 11%, 9% had complete resolution of pyogenic granuloma at the end of 8 weeks. First diagram shows the patient at the time of presentation, second diagram at the 4 week of treatment, and third diagram at the 6 week of the treatment. Now discussion pyogenic granuloma occurs secondary to local tissue hypoxia with traumatized endothelial cells which result in expression of the growth factors such as vascular endothelial growth factor and basic fibroblast growth factor, leading to the aberrant healing and the eventually mass formation. In addition to corticosteroid, the other treatment modality used in treatment of ocular pyogenic granuloma include cryotherapy, electrocortic topical antimetabolite, intralesional steroid, and plug irradiation. Side effects of steroid include steroid-induced ocular hypertension can lead to the steroid-induced glaucoma following the prolonged use. Other potential side effects include the opportunistic infection and cataract formation. Topical timolol has been used as an alternative to steroid for the treatment of pyogenic granuloma. According to the Ocatel report outcome in the 4 children who had a conjunctival pyogenic granuloma, all cases complete resolution occur within a treatment period with no recurrence for at least 3 months. There were no adverse event from the timolol during follow-up. According to the D. Mary et al. Reported outcome in 17% with ocular pyogenic granuloma, 88% of the patient had complete lesion resolution with the mean treatment duration approximate 3 weeks and no adverse event or recurrence with the mean follow-up up to 9 months. In our study, success rate with the use of topical timolol with 82% of patients responding to the topical therapy with minimum fluctuation of intraocular pressure. Now conclusion, topical steroid therapy, although convenient, is not free of side effect. Topical timolol has been used as an alternative to steroid for the treatment of pyogenic granuloma. Topical timolol cause significant but reversible reduction in IOP. In all patients, no adverse reaction were reported. These are some references.
Yes, would you like to ask some question?
Thank you. I just have a question. What exactly was the rationale in adding intraocular pressure in your study?
Ma'am, intraocular pressure increased, might increase during the treatment, but reversible after the stopping with the treatment.
No, you mean to say that you're given timolol and you expect that the pressure will rise?
Sorry, ma'am, decrease in pressure.
Plus, you have said that the intraocular pressure was not significantly. According to your, please can you quote to me how much was the pressure decrease? There was, if I'm not mistaken, 4 to 5 millimeter pressure decrease. Ma'am, which was the instrument that you used to check the pressures?
Ma'am, applanation tonometry.
How old were your patients?
Ma'am, it differ from the 7 to 45 years.
7 to 45 years.
Yes, ma'am.
That's a huge age range. What is the mechanism of action of timolol in the use of pyogenic granuloma?
Ma'am, timolol decrease the inflammatory mediator which causing the pyogenic granuloma.
And how long did you use the timolol? Use timolol for decreasing it?
Ma'am, 8 weeks.
8 weeks.
Right. Thank you.
Thank you. Next, we have Dr. Venkata Prabhakar, who will be presenting retroconjunctival RF cautery, a fine needle for conjunctivocalysis.
No?
Dr. Shebe?
Dr. Shebin.
This presenter is not there.
Very good afternoon to all. My topic is clinico-demographic profile and management outcomes of periocular and subconjunctival dirophyllariasis, which is an emergent zoonosis. So dirophyllariasis is a zoonotic filarial infection caused by the filarial nematode of the genus Dirophyllaria. There are main 4 species which is causing human infection, including the ripens, imitis, tenuis, and ursi. The major reservoir host is canines, and humans are the accidental dead-end host. The transmission is via the mosquito vector. So the purpose of the study is to report the demographic profile, clinical features, management aspects, and outcomes, and also to discuss the management based on their anatomical location. So this was a retrospective observation study with a total number of 53 patients. All patients with histopathologically or microbiologically proven periocular and subconjunctival dirophyllariasis were included over a study period of 9 years. And the data analyzed included the clinical demographic features, imaging, findings, microbiological, histopathological findings, and the management. The mean age at presentation was 48.27 years, but it was ranging between even 10 months to 78 years, and 5 patients were in the pediatric age group. The mean duration of symptoms was 1.40 months. So this was the number of cases reported per year. So here we can see that over the recent years, there is an increase in the number of cases reported with a sharp dip in the year 2020, probably because of the COVID pandemic, where the population was staying inside with less chance of the disease transmission. And in the year 2021, we collected data till the mid-year only. And the district-wise distribution, the Ernakulam and the Alapura district were showing the maximum number of cases. Though the study center was also located in the same area, the mosquito density is very high in these localities. Symptom-wise, the lid swelling was the most common noticed, followed by redness, mild pain, itching, conjunctival mass, foreign body sensation, watering, and facial swelling. A lid mass was the most common sign noted, followed by lid edema, conjunctival congestion, subconjunctival nodule, subconjunctival live worm, chemosis, proptosis, suprabromas. Imaging was done in a total of 18 patients, including CT, MRI, and ultrasonography. CT and MRI was often non-conclusive, showing a ill-defined cystic lesion with rim enhancement if contrast is given. On the contrary, the USG is very much of diagnostic. Here it is a video showing this hypoechoic lesion with mobile linear structures with parallel echogenic walls. So these are highly suggestive of a live parasitic infestation. In the location-wise, a lid followed by the subconjunctival space was the most common location. We had 2 cases where it was localized in the orbit also. In the tissue plane-wise location, the cyst was often localized within the orbicularis muscle and also in the subconjunctival space. Even within the fat also, the worms are often seen. A total of 30 patients received conservative treatment before surgery as they presented with the signs of inflammation. But in 23 patients, we directly intervened and did a direct worm removal or excision biopsy as they presented with either subconjunctival live worm or with a very well-defined lesion. So in total, excision biopsy was done in 44, direct worm removal in 8. Complete resolution was noted in all patients. In humans, the dirophyllaria can cause subcutaneous or submucous nodule or worm, rarely pulmonary disease, and sometimes intraocular disease also. The presentation varies depending upon the location. Even subconjunctival worm itself can present in two ways, either as a live worm, in which case the patient can present with redness, foreign body sensation, even sometimes the feeling of worm moving. But once it forms a capsule, the patient becomes relatively asymptomatic. And when the subcutaneous worm, depending upon the location, it can mimic several diseases. If it is present in the supratemporal area, often as dacryoadenitis. When it is present in the near the lacrimal sac, can mimic dacryocystitis or even as a lid tumor. So when to suspect the disease? When the symptoms are of waxing and waning course with varying locations, often migratory swellings. When the initial diffuse swelling with treatment become well-defined swelling, and when there is lack of signs of inflammation except for edema. We often call it white edema because there will not be any erythema or any tenderness. And the management, especially in case of subconjunctival live worm, there are few tips. We have to prevent the migration and escape of the worm, so that for which it is better to avoid the bright light for examination. Topical atropine eye drops can be used for immobilization. And when we are infiltrating, first give in the conjunctiva between the worm and the fornix. In that way, it will prevent the migration, create a pharmacological barrier. In the morphology, we can differentiate between dirophalia repens and emitters based on its thick cuticle, muscle coat, longitudinal and transverse striations. So to conclude, it is an important differential diagnosis, especially in the parts of Kerala when the patients present with the periocular migratory swellings, conjunctival nodules, periocular masses of acute onset. The imaging of choice is ultrasonography. In suspected cases, it is diagnostic, cheap and easily accessible. Surgical treatment is both diagnostic and therapeutic. But regarding the medical management, it needs further research to validate its utility in the management scenario. Thank you.
Very nice paper. Thank you.
Thank you.
The ones that you have done, only that. Right. I think we've finished for the day over here. Thank you all the speakers. Thank you all very much. That was very interesting. And we all, as I said, learned a lot.
Thank you.